So I'm Patrizia Inácio, Bionews Services correspondent for Friedrich Ataxia News. Dr. Rummey, thank you for being part of Friedrich Ataxia News' official coverage of the International Ataxia Research Conference here in Pisa, Italy, and for agreeing to do this filmed and recorded interview. So our first question is, why is loss of walking ability, what is known as independent ambulation, such a crucial and debilitating milestone for FA patients, and what does it often precede?
Well, I don't think you really need to explain why it's such a crucial event. Losing ambulation is a big event for everyone who has to suffer from it. And the difficulty is a little bit what happens after, because patients, after they lose ambulation, are really hard to study, and that's known. So there are things you can still measure after they lose ambulation, which is all the functional tests with the hands, like or the speech, and these are the things that you can do. But it becomes really hard to actually follow the disease progression of these patients after they lose ambulation.
The typical age of onset for Friedreich's ataxia is put at between 5 and 15 years old. What was the typical onset age for the 389 patients in this presentation who generally began to experience walking problems around age 14 and a half and lost ambulation around age 25?
I know that this was probably one of the biggest cohorts that anyone has ever looked at loss of ambulation, and I think the mean age of onset with them was around 8 years. It was like 8.2, 8.3 years. But it's probably so many patients that it's representative for this type of patient with that early onset. Yeah.
This study aims to document the range of FA clinical symptoms and disease progression. Among those you have already documented, what are the most significant for patients, most significant in terms of disease progression?
So I personally haven't looked at this, and as far as I know, also no one else has looked in this study data for symptoms. But we're going to do this, and we're going to look at or use the exactly same methods. And then what you actually want to find is symptoms that happen pretty quickly, not over a big portion of patients, because the longer the time gets, the harder it will become to study it. And it's going to be really exciting to look at that. Yeah, but we haven't done it yet.
It is also looking at specific tests and measures for setting trial endpoints, goals, that are crucial to designing effective clinical trials. How can loss of ambulation work as a relevant endpoint in clinical trials?
Well, that's a good question, and many people think it cannot be done. But I'm not saying it cannot be done, but it will be difficult, simply because it takes so long, because it's a long process. And what people like Dave Lunch say is you can maybe approve a compound based or prematurely approve it based on a different endpoint that can be measured more quickly. And then you follow patients up and see if it also works on their loss of ambulation. That's something you can do, maybe. But doing a study solely on loss of ambulation will probably take a couple of years, and no one will try to do that at the moment.
You report over 900 patients enrolled among the study's 12 clinical sites. How many are you hoping to in total to enroll? When does this study begin, and when it might finish?
Yeah, so actually I don't know why anyone would ever finish to do that, because you can just never get enough data. And what I know from the people who organize this, I think they have no intention to stop anywhere near in the future. Yeah.
Data gathered at each study site is being collected in a database. How substantive is this database now, and how is the data being used? Is it already open to researchers working in FA in the clinic and in FA trials?
That's a very important point, because we actively try to talk to companies who design trials. We have seen so many trials failed, and many of them have just been wrongly designed to show an effect. And then a company runs a trial, is not successful, and then they give up the project. So we can't really afford that anymore. And that's why CCRN actively tries to work with companies to design better trials using this data.
Okay. Thank you so much for your interview.
You're welcome.
Thank you.